Most men have never had an honest, accurate conversation about female sexual anatomy. Not from their doctor, not from their parents, and certainly not from the way it gets depicted in media. And that gap in knowledge matters more than most people realize, because the anatomy of arousal and sexual response is specific, physiologically fascinating, and directly connected to the same systems of blood flow and vascular health that I discuss on this channel every week. As a urogynecologist and urologist, I am in a relatively unusual position. I treat both male and female pelvic health in the same practice. I understand the anatomy of both systems, how they interact, and what happens at the level of blood flow, nerve activation, and muscular response during intimacy. Today I want to share what that clinical perspective actually looks like. The anatomy most medical education skips, the blood flow science that explains arousal, and why a man's own vascular health is more connected to his partner's experience than most couples ever discuss. My name is Dr. Elizabeth Kavaler. I am a board-certified urologist and urogynecologist with over 20 years in clinical practice. Urogynecology is the specialty that sits at the intersection of urology and gynecology. I treat conditions of the bladder, pelvic floor, and urinary system in both men and women. Female sexual anatomy is something I work with clinically every day. What I share today is grounded in anatomical research, published studies on female sexual response, and the clinical understanding that comes from treating patients in this space for 2 decades. Let me start with an anatomical fact that surprises most people. What most people think of as the clitoris, the small external structure visible at the top of the vulva, is only the very tip of a much larger internal structure. The full clitoral complex is shaped roughly like a wishbone. The external glands, the visible part, is attached to a shaft. Below the shaft, 2 internal arms called the crura extend backward along either side of the vaginal canal, attached to the pubic bones. Alongside those, 2 vestibular bulbs sit on either side of the vaginal opening. The entire structure is erectile tissue. The same type of tissue that fills with blood during male arousal fills the clitoris, including its internal arms, during female arousal. This engorgement is what produces the sensitivity and tension that characterizes full sexual arousal in women. Research by Dr. Helen O'Connell, published in the Journal of Urology in 2005, used MRI imaging to map the full clitoral anatomy in detail for the first time, demonstrating that the internal extent of the clitoral complex is significantly larger than anatomical textbooks had previously shown. The vestibular bulbs alone can reach 3 to 4 centimeters in length and surround much of the lower vaginal canal. Understanding this anatomy changes everything about how you think about arousal. Indirect stimulation through pressure, vibration, or sustained contact anywhere over this internal structure, not just direct contact with the visible external glands, activates the same erectile tissue response. Female arousal is fundamentally a vascular event, the same statement that is true of male arousal. The mechanism is nitric oxide-driven vasodilation of the blood vessels supplying the clitoral complex and vaginal tissue. Nitric oxide production in genital tissue is stimulated by sexual arousal through the parasympathetic nervous system. It signals the smooth muscle in genital blood vessels to relax, allowing increased blood flow into the erectile tissues of the clitoris and the vascular subepithelium of the vaginal wall. This produces engorgement, sensitivity, vaginal lubrication, which is actually a transudate, a plasma-derived fluid that seeps through the vaginal wall as blood flow increases, and the heightened sensitivity that characterizes full arousal. This is exactly the same nitric oxide pathway that governs male erection, which means that the same factors that impair nitric oxide production in men, cardiovascular disease, high blood pressure, diabetes, poor sleep, smoking, alcohol excess, also impair arousal physiology in women. Sexual function in both sexes is a reliable indicator of overall vascular health. This is why my previous videos on beetroot juice, morning foods, and nitric oxide production are relevant not just to men's sexual health, but to couples' sexual health more broadly. Improving systemic endothelial function improves the vascular response that arousal depends on, regardless of sex. Female ejaculation is a topic surrounded by cultural confusion and scientific debate. As a urologist, I want to give you the clinical picture based on what the anatomical research actually shows. There are 2 distinct phenomena that are often conflated. The first is vaginal lubrication. the transudate I described, which is a product of increased blood flow through the vaginal wall. The second is fluid expulsion, which involves the Skene's glands, also called the female prostate. The Skene's glands are small glandular structures that drain into the lower urethra. Research using immunohistochemistry has confirmed that they contain the same prostate-specific antigen markers found in the male prostate, which is why they are sometimes called the female prostate. These glands can produce and expel a small amount of fluid during orgasm. There is also a separate phenomenon involving the bladder. Ultrasound studies, including one published in the Journal of Sexual Medicine in 2015, found that in some women, the bladder partially fills during arousal and expels fluid at orgasm that contains trace markers of urine alongside Skene's gland secretions. This is not a malfunction or incontinence. It is a physiological event in some individuals, likely related to periurethral gland anatomy and the proximity of the clitoral complex to the bladder neck. I share this not to be explicit, but because understanding this anatomy removes shame and confusion for both partners when it occurs. It is a normal physiological variant, not a problem to be managed. I want to come back to something I mentioned earlier, that arousal is a vascular event for both sexes, because the practical implication of this is worth stating clearly. A man's ability to achieve and maintain a firm, sustained erection is directly connected to the quality of his partner's arousal experience. The physical pressure, friction, and stimulation of the clitoral complex and vestibular bulbs depends in part on the man's erectile firmness. A softer erection produces less stimulation of the internal clitoral structures. This is not a judgment. It is anatomy, and it means that the habits and interventions I discuss for men's sexual and vascular health, the daily walking, the dietary nitrate foods, the pelvic floor exercises, the management of cardiovascular risk factors, are not just about the man's experience. They are about both partners. A man who prioritizes his vascular health, his pelvic floor function, and his erectile quality is investing in intimacy for two. That framing changes the motivation for a lot of men I see who have been slow to address these issues. The competitor video I am responding to describes a technique called Kunyaza, a traditional Central African intimate practice that focuses on sustained contact with the external and internal clitoral complex using rhythmic motion rather than penetration-focused movement. From an anatomical standpoint, the clinical logic is entirely sound. Kunyaza, as described, produces rhythmic pressure and vibration over the external clitoral glands and the area overlying the internal vestibular bulbs and urethral sponge, which is the area sometimes called the G-spot. This sustained stimulation of the full clitoral complex through multiple contact points is consistent with what we know about how clitoral engorgement and orgasmic response are physiologically achieved. The clinical takeaway is straightforward. Techniques that prioritize sustained, varied stimulation of the clitoral complex, including its internal extent, over penetration, as the primary focus are consistent with the anatomy of female arousal. This is not a secret technique. It is applied anatomy. And understanding the anatomy is what makes it accessible without cultural mysticism. The conversation about sexual health and anatomy for both men and women deserves to happen openly, honestly, and without shame or sensationalism. The anatomy is fascinating, the physiology is well documented, and understanding it produces better outcomes for both people in an intimate relationship. As a urogynecologist and urologist, this is genuinely at the center of what I do. The pelvic health of men and women, the vascular systems that make arousal possible, and the conditions that affect them are not separate topics. They are one integrated clinical picture. I hope today gave you a piece of that picture that your doctor has not had time to cover. I am Dr. Elizabeth Kavaler. I will see you in the next video.